Welcome to our Mary Greeley Primetime Alive presentation, What's an Esophagus Attack? I am Wendy D'Amato and I help coordinate the Primetime Alive program. As a reminder, if you would like more information about Primetime Alive or how to join, please visit our website, mgmc.org/PTA. Our presenter today is Dr. Douglas Lake. Dr. Lake received his bachelor's degree in biology at Loyola University Chicago and his medical degree from the University of Kansas. He completed a residency in diagnostic radiology at Medical University of South Carolina and a fellowship in clinical MRI at Stanford Hospitals and Clinics. Dr. Lake joined McFarland Clinic's radiology department in June of 2015. So please welcome Dr. Lake.
The clicker, okay. Thank you, Wendy.
You're welcome.
All right. So I'm Doug Lake. I'm a radiologist here at McFarland. I appreciate the introduction, Wendy. I'm here to talk about esophagus attacks. This is a term that I've coined for problems with swallowing that cause pain in general. But I'm going to start right off. If I can, let me see if I can advance. I'm seeing changes on the screen, but not changes. Click on there. Okay. So picture me about 20 years ago, or maybe closer to 25 years ago. I was a medical student. I had run the turkey trot in Kansas City. I was a healthy medical student. I'd run the 5K, and I was famished. I finished the race. I had a couple energy bars, drank some liquid, either Gatorade or water, and our family always met for Thanksgiving in Omaha, or Bellevue actually, just a little bit south of Omaha. So I finished the race, get in my car, drive up to Omaha, see all my family at Thanksgiving, sit down to eat, and I'm famished. I said it once, I was so hungry I could eat a horse. And so had this great plate of food in front of me. It's about 2 o'clock in the afternoon. I cut into the dark meat. I hope I'm not offending any of the white meat lovers out there, but cut into the dark meat of the turkey, take my first bite, swallow it down, and there's this pain that I've never experienced before in my life. This deep-seated pain right in the middle of my chest. A little bit of pain here, a fair amount of pain here. First thoughts are, am I having a heart attack? And I'm a dangerous medical student at this point. I'm either a second or third year medical student. But I instantly ruled that one out, going, no, it can't be a heart attack. I just ran a 5K this morning. I'm in my 20s. There's no chance. What else could this be? Is this aortic dissection? Is my aorta rupturing in my chest? No, that's not the case. I'm in my 20s. I'm healthy. Is this reflux disease? Am I refluxing something? No, it's happened within 5 seconds of swallowing this food. What is causing this pain? And I thought and that finally arrived at, oh my gosh, is this cancer? Is this something blocking my esophagus, some abnormal growth that's causing this thing to get stuck in my esophagus? And with that scary thought, I ended up taking care of it on my own, but I'm going to move the slides forward. But I'll tell you, the patients that I've talked to for the last 20 or so years about this problem tell me a similar story, usually about chicken or turkey or beef, something getting stuck and having this exquisite pain. And they all express very similar things, even though the age can be very different between my age and folks in their 60s or 70s. There's a sense of uncertainty. What is this? What am I experiencing? They're often scared. We're often frightened. I climbed into what I call my fear cave. I didn't tell anyone about it. I just went about my business and hoped that it would never happen again. I also felt like this was the first thing that's ever happened to a human being before, which is completely ridiculous. But that's what I felt. And in talking to other patients who've had this, they feel like this is a unique thing that no one else has experienced. And part of it is because we as humans don't talk that much about, we may talk about heart attacks, we talk about cancer, but we don't talk about food getting stuck as much in the esophagus. So I'm here to assure you, though, that this is really common. It's an estimate, but 65,000 Americans visit the ER every year with food impactions that have to be disimpacted. So that's an average of 170 people per day that present all across our country with this problem. We guess that about 250,000 Americans are able to clear food impactions on their own with the things that they do. Some of the things I'm going to talk about in this presentation. But who's at risk for this? Well, there's 23 million Americans who suffer from gastroesophageal reflux disease, which is stomach acid coming up into the esophagus and slowly causing damage over time that can eventually narrow the esophagus and cause the sense of food getting stuck. So today, I'm going to walk you through a little bit of the anatomy with a big emphasis on make sure you see your doctor if you have this problem, or support friends, family, or others that you know who may have this problem. I'm going to walk you through my three simple step way of dealing with this problem. Talk briefly about how lifestyle changes are better than medicines for this, but medicines have their role, and then talk about what next steps may be necessary. If you go to sleep and forget everything from this presentation from now on, please take this last bit of information in mind, which is that 99% of the time that this happens, it's not cancer. Okay? Keep that, repeat that to yourself. 99% of the time that this happens, it's not cancer. Less than 1% of the patients who present with this sense of food getting stuck, or esophagus attacks, as you will, have cancer. But cancer does happen and can cause this. This is a simple diagram of your esophagus. This is going to be medical school 101, and it may be even simpler than that. We eat food in our mouth. We swallow it down our esophagus. We have an upper esophageal sphincter, which is a strong muscle that helps keep the esophagus closed. We also have a lower esophageal sphincter that helps keep the esophagus closed. And in between, there's a combination of skeletal muscle in the top third and smooth muscle in the lower third. What you need to know is that you have very limited control over your esophagus. You have great control over the rest of your muscles. You can move your hands and arms and legs and all of that. Your esophagus you only control when you swallow. And when you swallow, you initiate a complex set of interactions between the muscles of your mouth and your neck and your spinal cord that then initiate further activity throughout your esophagus. What happens as we see our images when we take an esophagram, is that the esophagus contracts in a nice organized pattern, contracts and relaxes, and helps food move through. The upper esophageal sphincter opens, allows things to pass. The rest of the esophagus allows things to pass. And the lower esophageal sphincter briefly opens and then closes and prevents things from the stomach to move upward. I explain to patients our GI tract's a one-way street. Things come in our mouth and they move through our GI tract. They're not supposed to go in the opposite direction. Now, we're going to move on to, this is another sort of tighter diagram of what happens and one of the problems that we commonly see associated with gastroesophageal reflux. So on the left side of your screen, you can see a normal esophagus with a normal lower esophageal sphincter. Keep in mind that the sphincter is just a muscular ring that helps hold the esophagus closed. Surrounding it is the diaphragm, which is the muscular layer that separates your abdominal cavity from your chest cavity. In most patients, the two of them are invested adjacent to one another, or the diaphragm is right around the esophagus. There are small ligaments that connect the diaphragm to the esophagus. A hiatal hernia is where that lower esophageal sphincter moves upward into the chest cavity, and it doesn't have the diaphragm around it to strengthen it or to give it more support. And so the lower esophageal sphincter doesn't close as well in the event of a hiatal hernia. We see this very commonly, and it can increase the chance of reflux. But again, a big take-home message is if you're having problems with food getting stuck, please see your doctor. And you can see a variety of different doctors to take care of this problem. But one of their biggest questions for you is going to be, are you experiencing weight loss? Does food get stuck, which is the case for this? Or do you have signs or symptoms of anemia, which is chronic blood loss or a low red blood cell count? And so when they see you, they're going to ask about these things. don't be afraid. These are questions that are very common, as well as other questions that they may have. How long has this been going on? What have you tried at home? Have you tried any medicines? Where does the pain occur? Does it occur here? Does it occur here? Is there pain somewhere else? So there'll be a lot of questions, and that's fine. As you're seeing your doctor, part of this disease and part of this process in talking with a lot of patients over a couple of decades is that there's a lot of deep-seated fears associated with this. Most patients fear cancer. I certainly did. That was the thing that I settled on as the most common cause for me. I've asked my patients, what do you fear about this after I've seen them and talked to them about what we have? And these are some of the examples that I've had. What I encourage all of you to do is, if you're experiencing this or any medical problem that is causing you emotional distress or fear, part of this is healing the problem, right? But part of this is also dealing with the complex emotions that come out of some of these medical problems that cause us long-term concerns. So work on, this was hard work for me, work on speaking your fear, whatever that is. And for me, it was, I'm afraid this is cancer. But I've heard other patients say, I'm scared to death of eating out and having this problem happen at a restaurant in town. I stopped hosting holiday dinners years ago. I'm worried about how much all of this workup is going to cost. I had one patient, I nicknamed her Angelina. All the names that I have here are all been changed twice, actually. But Angelina was a lady in her mid-90s who came in and she had problems with food getting stuck. And she was almost blind, had a very difficult time hearing, so I had to speak very loudly so that she could hear me. And when I asked Angelina, we did her esophagram, and I could see that she had at least a moderate stricture, so a long segment narrowing of her esophagus. It did not look cancerous, but she'd had long-standing reflux that had slowly damaged her esophagus over a period of decades, and her esophagus was very narrow, and it didn't open, so food got stuck. And when I asked her, what do you most fear about this, or what is your biggest concern, her question to me was, when do I get to eat people food again? And my heart just sank. I realized that she didn't consider what she ate to be what other people ate. She didn't feel like she was human anymore because she couldn't eat any normal food anymore. My emphasis is take care of this before you get that far down the road that you have a severely scarred esophagus. She was going to go on to get treatment, and there is treatment for this. You can get an upper endoscopy and a ballooning of your esophagus where the esophagus gets dilated back open. But this is such a disease that it's much better to take care of early and to address early than it is to let it go on for years or decades and slowly damage over time. So when you see your doctor, one of the things that you'll be likely given is a medicine called a proton pump inhibitor. There's about 6 different medicines in this classification, or this class of medicines, and they all are very, very good at helping with reflux. And it's counterintuitive. They don't actually stop things from refluxing. They change the acidity of the stomach. The stomach is the most acidic environment in the human body. We excrete very strong acid into our stomach to begin the digestive process. The proton pump inhibitors block some of the stomach's ability to secrete acid, and so your stomach is not as acidic. Things will still reflux up. So there's a lot of patients who I see after they've been given a PPI who say, I took it for a couple days and it didn't change. I still could feel stuff in my esophagus. I could still feel this nasty taste in my mouth. And I try to carefully explain that's not the role of the medicine. It changes the acidity so that things move up, that they don't harm your esophagus. Your doctor will likely order some labs, particularly the CBC, to see what your blood counts are. They likely will refer you to either gastroenterology or radiology, depending on your symptoms and depending on the other things that are going on with you. And you can have a variety of different imaging studies or evaluation from the gastroenterologist. The gastroenterologists also have additional tests that they may do in addition to endoscopy. So endoscopy is putting a camera down the throat and into the esophagus to look and directly see if there's anything there that's causing a problem. While they're there, they can take small pieces of tissue in the form of biopsies if they see something that looks abnormal. Our imaging for a radiologist is to do an esophagram or upper GI, which is where we give you just some contrast to drink. You're able to drink it, and it goes through, and we take pictures while it goes through. The advantage for our study is it outpatient. You're able to walk out afterward. There aren't any limiting factors in that sense. Whereas with the endoscopy, it is a better test than our esophagram, but there's the issue of having to get sedated and then wake up from sedation and then have somebody take you home and take care of you afterward. But there's a variety of tests that can be done to help sort out these problems. Now, this is going to transition into how do I deal with the problem that I've had for years. In my first story, I'm going to tell this in a series of stories, and I hope that illustrates all of the examples a little bit better. But my first rule that I tell patients is liquid before solid. And what does that mean? Well, I had a patient who came in and she explained that the night before she'd had a steak dinner, salad, green beans, all this stuff, and she had no problems. She said, I swallowed all this stuff fine, but doc, I was feeding my cat the next morning, and her cat's lucky, her cat gets lunch meat. She said she cut up some lunch meat for her cat, she took a bite of it, swallowed it down, she said, doc, it got stuck, I don't understand. And I explained that one of the rules of this, and one of the very simple things that we do with swallowing is that often when we sit down for meals, we take a drink of liquid first. And it does two things. One, liquid combines with your native mucus to make your esophagus literally slicker, just physically slicker, so that things move through easier. The other thing is that your esophagus is a muscle, like the other muscles in your body. Eating a solid, especially a meat, is one of the hardest things that you can swallow at a time, and it's more likely to get stuck. And so liquid helps your esophagus muscles literally wake up and realize that they need to contract and relax in an organized fashion to try to help move solids along and through. So Olivia, the solid was taken first before any liquid, and it got stuck, and it caused the problem. My second very simple rule is easy solids before difficult solids. Again, seems elementary, but as you're sitting down to eat, for me, my mistake commonly is I'm sitting down for a steak dinner or a chicken dinner or something like that, and I want to have the steak first or the chicken first. And in Michelle's case, she told me the same story where she sat down with her family for a Easter meal. She had ham, she had peas, she had mashed potatoes, she had liquid. She sat down with her family, and they toasted before the meal, so they said their prayer, and then they had a family toast to all getting together at Easter. And she took liquid, several sips of liquid, gulps of liquid, no problem. And then her grandson took a bite of her ham that she'd spent all day cooking and preparing and said, "Grandma, this is the best ham I've ever had." And of course, Michelle looks at the ham. That's what I want to have next. Takes a bite of the ham, swallows it down, and instantly in front of her family has pain in the middle of her chest. She has an esophagus attack right in front of her family. And she has to excuse herself from the table to try to get it cleared, and felt embarrassed and just had a lot of emotional turmoil that came from that. But the message was, you're still warming your esophagus up as you take your first few bites. And so it's often best to take small bits of food, peas, corn, mashed potatoes, things that you know are going to pass easily before you start diving into the more difficult things. I liken it also to warming up before any kind of exercise. I used to be a football player, and long ago, or a track person. I would never walk out on the track and take off for a 400-meter race without warming my legs up first, or doing some jogging, doing some active stretching. The same holds for your esophagus. If you're a golfer, you're not going to walk out on the course. Tiger Woods doesn't try to swing for 300 yards without warming up his back and his muscles first. And the same is true for your esophagus. You do want to warm yourself up before you tackle any of the difficult solids on your plate. And then finally, Tim was a patient that I saw. He was in his 50s who really illustrated the flush with liquid rule, which is my third rule, which is that every solid bite should be flushed with liquid. Tim told me that he was sitting down for a meal. He was eating a good diabetic meal, which was some vegetables, some steamed broccoli, some steamed corn, and some salmon. And he drank liquid first, had his solids, and he had a first bite of solid, and a second bite of solid, and a third bite of solid, and then realized, something is stuck. And Tim's issue was that when we brought him in for the esophagram, had him swallow. We have everybody swallow a 1/2 inch pill that is 13 millimeters in size. It's a size that if it gets stuck, you need to have your you likely need to have your esophagus dilated. Well, Tim had an esophagram, had a tight esophagus, had a stricture, a narrowing in his esophagus, in the distal esophagus. Tim took the pill. It got stuck. And I ask everyone, I feel a little bit like a CIA agent because I can see what's going on inside, but I want to see what their symptom experience is. Do you feel like it's stuck? Tim says, no, went right through, no problems. I said, well, take another sip of liquid and see what happens. And he took another sip, still felt fine, took another sip and said, oh, Doc, I think it might be stuck. And at that point, his esophagus was about 10 centimeters full of liquid, which with diabetes, it's a disease where your blood sugars are high, and over time that slowly damages peripheral nerves in your body. So your feet may go numb, your hands may go numb, and in Tim's case, the nerves to his esophagus, their long nerves, they were not functioning normally. And so he wasn't able to feel that something was stuck until it was really stuck, till he had several things stacked up on top of each other. So every solid bite, flush with liquid. And my final example of all of this was there was an 80-year-old or so patient, Hal, I name him, who was an old plumber. And I ask all of my patients, what makes this better? What seems to help? And Hal looked at me and said, well, Doc, I'll tell you what, it's taken me a few decades to figure this out. But what works for me is I got to wet my whistle first when I sit down at the table. So I got to have some liquid first. Then I eat the little bits on my plates. His words, I eat the little bits, the little things on his plate before he eats any of the big bits. And he said, Doc, and it took me a few years to figure this one out too, but I got to flush every bite with some liquid. And I looked at him and said, how'd you figure that all out? He said, oh, Doc, it's taken me 40 years to figure all of this out, but I'm an old plumber and I just kept tinkering with it, and this is what works for me. And Hal's story reinforced to me that I really needed to write this book. All of this seemed very simple and elementary to me, but I realized that if people could read this book or simply hear this presentation, they can accelerate 40 years of Hal's tinkering into just 3 simple rules to help them eat more easily with esophagus problems. So if you're out and you're eating, or at home and eating, and something gets stuck, what do you do? So a good example for me was I was out on date night with my wife, and we went to Basil Thai. It's a Thai restaurant in South Carolina. It had fantastic food, and I always got the same thing, the red curry duck. This day happened to be a day where I was on, I don't remember what service I was on, but I was busy and I skipped lunch that day. So I came to the common story for me. I came to the place famished, and what do? I did the same thing I did in Thanksgiving dinner. I'm a slow learner sometimes. And so I cut into my red curry duck, took a bite, didn't take any liquid, didn't take any small bits first, swallowed it down, and bam, of course, you know where this is going. It gets stuck in my esophagus. So what do you do? Is there something that you can do to help clear it? What works for me and what works for other people that I've talked to? The first step is don't eat any more solid food. This is stuck in your esophagus. The esophagus, yeah, it's a tube, but it's a tube of muscle, and so it's going to contract down, the esophagus will, and surround the food, and the pain that you experience is because your esophagus is spasming against the food. So more solid food is just going to stack up and cause more problems. So no more solid food. The next step is tell someone what's going on. Now, I explained to my wife briefly that something feels like it's stuck and I'm going to try to get it cleared. You don't want somebody to assume that you're choking. Choking is a different scenario where you're swallowing food and it impacts in your trachea and you can't breathe or talk anymore. Choking is something that if you don't get the food cleared with a Heimlich maneuver or something else, you will not be able to breathe, and you will die within a period of a couple of minutes. So if you're able to talk after this, you're not choking on food, it has become stuck in your esophagus. So you want to let somebody know so that they know what's going on, and so that you can help relieve their emotional distress about seeing something happen. I then take little sips of liquid, just tiny little sips. I liken it to you've probably seen a creek where you see little bits of liquid pass around stones in a creek. And it's the same concept, is that most of the time the food is not 100% stuck. It's usually 90 or 95% stuck. And a little bit of liquid going through may help move the food along and may help get it to pass. My other trick is to stand up. My wife knows that if I'm eating food, I usually have a funny look on my face when something gets stuck, but I usually stand up within the first 30 seconds. It seems like as I sit, my esophagus is a little bit bent at my diaphragm because I'm sitting. I may hunch a little bit when I'm sitting down. Standing up seems to straighten out my esophagus and alters the angle just probably a few degrees, but it seems to make a little difference. The next thing that I typically do, again, this is not, I try to then walk away from my family, and I do let out a few little burps. And burping is retrograde flow of gas out of your esophagus and stomach and out of your body, right? So that little bit of gas coming out sometimes slightly reorients the bit of food and may help it pass. The next one is one of the hardest, which is to try to relax. And everyone always looks at me and says, God, food is stuck. It hurts like heck. I can't relax. Well, do your best, because many of the medicines that we give you to try to help this are muscle relaxants that are designed to relax the muscle. So if you can do deep breathing or do something that relaxes your overall body, sometimes that clenched down esophagus will relax just enough to allow a little bit more water to go through and may help something pass through. Finally, Valsalva maneuver. This is one that doesn't help me. I've never had success for me, but I've had several patients tell me they tried a Valsalva, which is bearing down your body like you're trying to use the bathroom, but don't use the bathroom. Try to bear down and kind of hold your breath and increase your abdominal pressure. Again, some people tell me this helps. Vomiting is an option. It sounds gross and awful, and patients, when they disclose it to me, often do it. I had to let things out and vomit. It's what works, and it may get things out. If all of this doesn't work, or if any of it is scaring you or you're concerned, you need to proceed to an emergency room to get help get this food out. Now, how do you avoid getting in that spot in the first place? Doctors, years ago, when I was a medical student, 25 years ago, I remember discussions between the doctor and the patient about changing things in their lifestyle. And there were a variety of things that were recommended at that time. Those are still valuable. We as Americans in society, we want our answer right now. We want it fixed yesterday, and we may not have the patience for lifestyle change. I want to briefly talk about some of the lifestyle changes that are beneficial for this problem. One of them is, I call it the 4-hour rule, which is simply give yourself 4 hours from the time that you eat until the time that you lay down to sleep. The reason being is that 4 hours allows your stomach to begin and end the digestive process and move everything in and out of the stomach so that there's nothing left to reflux up. That's the best way to try to help gastroesophageal reflux. I'm going to get a little bit of liquid here. I'm a little dry. The next thing to consider is no tight clothes when you go to bed. We know from studies that if we put a weight belt around people as they lie down and go to sleep, they have more reflux events when we test for that. My next rule is avoid the 3 Fs: fried, fast, fatty. Things that are full of fat take longer to pass through the stomach. Exercise and maintaining a healthy body weight is also important to help reduce reflux. Eating clean. If you Google eating clean, you'll see there's a whole bunch of websites and tons of books about eating clean. The general concept is trying to avoid highly processed foods as you eat them. There's a great book about clean eating as it relates to gastroesophageal reflux disease called The Acid Watcher Diet. It's a fantastic book. I've read it. I can recommend it for folks who have gastroesophageal reflux. It is a very structured eating program for the first couple of months and greatly reduces the amount of processed foods that people eat, but it's very helpful for this. And then some basic things. stop smoking if you do smoke. We know that cigarettes and other forms of smoke relax the gastroesophageal junction and allow more reflux. Vaping, we don't have studies to prove that vaping does it, but vaping causes all sorts of problems, and don't vape if you do. Try to lose weight, but that is, as we know, much easier said than done. The medications for gastroesophageal reflux are typically proton pump inhibitors, or given more than H2 blockers. Most doctors are going to give these to you for 30 or 60 days, and you can even buy them over the counter. They are that safe. So if you want to try to treat this on your own, you can by purchasing proton pump inhibitors or H2 blockers to help reduce gastroesophageal reflux. And finally, what next? If you have this problem, get help. See your doctor and ask for help. If you have friends or family who are having problems with food getting stuck, support them. Encourage them to see others. This is my email address. You can feel free to email me with stories. As a physician, I can't provide medical advice or medical care over the internet or email, but I'm certainly, my email address is in my book, and it's a great way for me to hear from others about what works for them or what successes they've had, or if this has impacted them in a positive way. And then finally, I am on social media, but Twitter is probably the thing that I'm most active on. Lately, you'll see more about vaccines in my Twitter feed than esophagus problems, but that's the nature of our world right now. So I hope you're all well. And I've tried to leave plenty of time for questions, so we'll just move on from there.
Okay, got some questions showing up here. Let's see. Well, I think we've got some stories too. So we have one that said there's 2 sizes for the mouth as far as endoscopy. I have a small mouth and they used too large one the first time. I had pain afterwards. Then they used the small one, no pain.
There are different sizes for the endoscope. Yes, there are different sizes for the endoscope. There are actually more than 2 different sizes, and they have them down to pediatric endoscopes that can be, that depending on the size of your mouth and throat, they may need to downsize the scope to get through.
She said they can do a gluten test while in there taking a small biopsy. I never knew that and had gluten problems also. She was just sharing those things she's learned.
Yep, there's a variety of things that can cause problems. Gluten can cause a lot of different GI problems. Eosinophilic esophagitis is probably, after GERD, one of the next most common causes of esophagus problems, especially in folks under the age of 40. So.
And then your 3 Fs, they were?
Fried, fast, and fatty.
Okay. All right. Any other questions from any of you? I think Dr. Lake was very informative and a lot of detail, so it was an excellent presentation. I learned a lot, and can you safely taper off PPIs after decades?
Great question. That's one that you follow up with your doctor with. But yes, folks can taper off of PPIs. The risk profile, it really depends on the person and their individual esophagus problems. You can try to taper off PPIs. There are, again, very low risks associated with taking PPIs for a long time, but there are some small risks. So if you can avoid, I've always been a practitioner that if you can avoid being on a medicine or if you can avoid an intervention, please do so. So it's worth trying, and yes. So
I know I personally went from every day down to just twice a week. So over the years, I was able to do that. So I know the person who submitted that, so we can visit too. Any other questions that we have for Dr. Lake? Great information. Thank you. Yes, it was very informative because I've dealt with this for years myself. All right. Well, thank you, Dr. Lake, for your time in preparing and presenting the program. I do have some questions of my own for you. So I'd like to remind everyone of our upcoming primetime programs. We have tomorrow starts a 3-part series on Alzheimer's. with presenters from the Iowa chapter of the Alzheimer's Association. And our next two programs are part of this series. The first one is Understanding Alzheimer's and Dementia, which is tomorrow, Thursday, August 12th at 2 p.m. And the second one is 10 Warning Signs of Alzheimer's on Thursday, September 9th at 2 p.m. If you need help with signing up or anything, just go to mgmc.org/PTA. And once again, we thank you for joining us today.